Okay, team, welcome to chapter 29. This is head and spine injuries. I apologize about the camera. Still having a little bit of trouble getting that to work, so we're going to go without the camera today. Trauma. Again, is discussing some of the standard competencies. This applies fundamental knowledge to provide basic EM care. Interpretation based on the assessment findings of an acutely injured patient. We want to recognize life threats and spine trauma. Main things we're talking about. Some of the pathophysiology, assessment, management of the spine trauma, and the skull fracture. We'll discuss that in our meeting today. And then we also want to take a look at the nervous system trauma. Pathophysiology, assessment, management of traumatic brain injuries, and spinal cord injuries today. The nervous system is a complex network of nerve cells that enables all parts of the body to do their function. So this includes the brain, spinal cord, nerves, and nerve fibers. So you have usually the central and the nervous system and the peripheral nervous system. We'll discuss a little bit more about this stuff today. The nervous system is very well protected. The brain is protected by the skull, and the spinal cord is protected by the spinal canal. Despite this protection, though, serious injuries can damage the nervous system. But as you would guess, they need to be pretty significant injuries, and they are. The nervous system is divided into two anatomical parts, the central and the peripheral. Here's where it's good to look at this, okay? So the central nervous system is everything basically kind of this start in the brain, the sensory motor areas of the brain in the spinal column. Okay, come down through here. Then everything that goes out is the peripheral nerve. Okay, so from the brain, down the spinal cord, central, rest peripheral. So central nervous system includes the brain and spinal cord. The brain controls the body and is the center of consciousness. The brain is divided into three major areas. You have the cerebellum, the cerebrum, and the brainstem. Here's a picture of this, okay? Just to give you an idea. So you got the cerebrum here, the cerebellum here, and then the brainstem coming down through here. Beginning through the foramen magnum and going to the spinal column. Oh, goodness gracious, I'm so sorry. Okay, the cerebrum, this controls a wide variety of activities, including most voluntary motor function and conscious thought. This contains about 70% of the brain's volume and is divided into four lobes or two hemispheres. The cerebellum coordinates balance and body movements, and then the brainstem controls most functions necessary for life and is the best protected part of the central nervous system. Okay, so this helps functions of cardiac, respiratory systems, and then nerve function and transmissions as well. The spinal cord is mostly made up of fibers that extend from the brain's nerve cells. This carries messages between the brain and the body, from the gray and white matter down to the spinal cord. There's a lot of protective coverings. The entire CNS is contained within a protective framework. The brain and spinal cord are covered with thick bony structures. The CNS is further protected by the meninges, three distinct layers of tissue that suspend the brain and the spinal cord within the skull and the spinal canal. So we try to protect it as best the body possibly can. The central nervous system is further protected by the meninges, as we discussed above. There's three distinct layers of that tissues that suspend the brain and spinal cord within that area. And so the outer layer is the dura mater. It is tough. It is a fibrous layer that forms a sac to contain the central nervous system. The inner two layers, called the arachnoid mater and the pia mater, they contain the blood vessels that nourish the brain and the spinal cord. This gives us a little bit look of as we're going from outside in. You've got the skin and then fascia, then muscle. Then you have the skull. Okay, so it's the outer table, inner table. Then you have the dura mater, the arachnoid. Okay, and then that's where cerebrospinous fluids comes in there. Okay, and then you also have the pia mater. That's in there. It's blood vessels, and then the brain finally right there. So you see how that kind of envelops everything in there. CSF, or cerebrospinal fluid. This is produced in a chamber inside the brain, really in the third ventricle. So there's approximately 125 to 150 mLs of CSF in the brain at any one time. It primarily acts as a shock absorber. So when injury does penetrate all the protective layers, you can sometimes have this clear watery CSF, which may leak from the nose, the ears, or maybe even an open skull fracture. So in the peripheral nervous system, there are 31 pairs of spinal nerves. These conduct impulses from the skin and other organs to the spinal cord. And these conduct motor impulses from the spinal cord to the muscles. So you got a lot of different things happening from that 31 pairs of spinal nerves. Here's an example of them, okay? So as you come out, you got the cerebellum, foramen magnum, then the brainstem, and then boom, you have the brachial plexus down here, the lumbosacral plexus, the spinal nerves. All these come out and do all the functions that we know of. The brachial plexus is what does the upper extremities. You have 12 pairs of cranial nerves. This transmit information directly to or from the brain. These perform specific and special functions to the head and face. This includes your sight, your smell, your taste, your hearing, and other facial expressions. And this is what we test most often in our neurologic examinations, the 12 cranial nerves. There are two types of peripheral nerves. One is a sensory nerve. Okay, these carry only one type of information from the body to the brain via the spinal cord. And you have motor nerves. This is one for each muscle. These carry information from the CNS to the muscles. You have the connecting nerves. They are found only in the brain and the spinal cord. These connect the sensory and motor nerves with short fibers and allow for the exchange of simple messages. So kind of how it all works. You have the nervous system controls virtually all the body's activities, including reflexes, voluntary and involuntary activities. So all those things come underneath control of the nervous system. The connecting nerves in the spinal cord form a reflex arc. Okay? If a sensory nerve in this arc detects an irritating stimulus, it bypasses the brain and sends a message directly to a motor nerve, causing a response. So here's an example. Connecting nerves in the spinal cord form a reflex arc. Okay, so boom, candle's getting hot here. That sends up to the reflex arc and immediately comes back and causes you to move. Okay, it bypasses the brain and sends a direct image or a message to the motor nerve. Voluntary activities are activities we consciously perform. Involuntary activities are actions that are not under our conscious control. And then you have somatic or voluntary nerves. Nervous system handles voluntary actions. So you have this somatic and somatic, all these different terms that you're going to see. But really it's describing voluntary versus involuntary. The autonomic or involuntary nervous system handles body functions that occur without conscious effort. So divided into two sections, the sympathetic and the parasympathetic nervous system. When confronted with a threatening situation, the sympathetic nervous system reacts to the stress with a fight or flight response. The parasympathetic nervous system has the opposite effect of the body, causing blood vessels to dilate, slowing the heart rate, relaxing the muscles, those kind of things. The two divisions of the autonomic nervous system tend to balance each other so that basic body functions remain stable and effective, or they stay in homeostasis. Skeletal system. We're going to talk about this a little bit. So here you go. The skull is composed of two groups of bones, the cranium and the facial bones, the main bones that we're looking at here, okay? Here's your cranium. These sutures are what grow as you're a child. Initially, there's a lot of cartilage here, and they grow out to your full size, and then they become completely fused together. The brain connects to the spinal cord through a large opening in the base of the skull called the foramen magnum. There are four major bones that make up the cranium. You have the occipital, which is the posterior, the temporal, the parietal, and the frontal. The face is composed of 14 bones, the maxilla, zygoma, mandible, nasal, and frontal bones. Now the spinal column, the body's central supporting structure, has 33 vertebrae. They are divided into 5 sections. You have the cervical, okay, thoracic, lumbar, sacral, and coccygeal. Here's where it's broken down, okay? So you got your 7 cervical up top here, your 12 thoracic, 5 lumbar, 5 sacrum, and 4 coccygeal. Now all these are kind of fused together down here. There's not a lot of movement there. All these right here all have lots of movement. They're not fused together and can cause lots of problems. And the front part of each vertebrae consists of a round, solid block of bone called the vertebral body. The back part forms a bony arch. A series of arches form a tunnel called the spinal canal, which encases and protects the spinal cord. The vertebrae are connected by ligaments and then are separated by cushions. These are called intervertebral discs. And that's how we kind of get the form and the function of the whole vertebrae. Now let's talk about head injuries for a moment. Head injury is a traumatic insult to the head that may result in injury to soft tissue, to bony structures, or to the brain. Head injuries account for more than half of all traumatic deaths, and fatal injuries invariably involve the brain. Be alert to the fact that the patient may have sustained additional trauma, even though they may see the head injury first. There are two general types of head injuries that we consider: closed head injuries and open head injuries. Closed head injuries are those in which the brain has been injured, but there's no opening into the brain. An open head injury is one in which an opening from the brain to the outside world exists, often caused by some sort of penetrating trauma. You may even have some brain tissue that's exposed or significant bleeding in that area. Falls and MVCs are the most common mechanism of injuries here. Head injuries also commonly occur in victims of assault or sport-related injuries as well. Here's a number of the signs and symptoms that you can see. This is a good table to review. This is in your book, 29-1. You can see lacerations, contusions or hematomas, maybe a soft or depressed area. Patients may have decreased mentation or confusion, irregular breathing pattern. That's where it's affecting the cranial nerves down there in the brainstem. You could have all sorts of other issues there, as we talked about. This is a good review. Scalp lacerations. Now, these can be minor, but they can be serious. Even small lacerations can quickly lead to significant blood loss, especially in little kids. So this is something you've got to watch really closely. I still remember being an intern. We had a guy with a pretty good head lac that came in, and he was a drunkard guy and fell and hit his head. And I remember thinking, oh, it's close to sign out. I'll go sign this patient out and then go finish this lac repair. Well, as I was going to get signed out, the attending was missing. I'm like, where's the attending at? And I went up there, and he was sewing up the head, which is like the biggest no-no to do as an intern. And so I've been in for like a month, and I was like, oh, no. So I got in there, got my gloves on, and finished sewing everything up. And he's like, he just said, hey, these can lose so much blood that pressure's often not enough. And so, anyways, a lot of times once you get into the ER, we got to sew those lacerations up pretty quickly. They could even cause severe hypovolemic shock. And then these could often be indicated in a deeper, more serious injury to that area. Skull fractures. There's significant force that applied to the head that is needed to cause a skull fracture. Maybe open or closed, depending on whether there's an overlying laceration of the scalp. Open, again, means communicating with the outside world. Injuries from bullets or other penetrating weapons frequently result in a fracture of the skull. Signs of a skull fracture include the patient's head appears deformed. You can have visible cracks in the skull. You can have significant bruising that develops under the eyes. Those are called raccoon eyes, or that develops behind one ear over the mastoid process. It's called a battle sign. This figure shows these pretty well. Okay, so the top one is raccoon eyes, and mastoid process or battle sign is B, that lower one. You can have a linear skull fracture. This accounts for about 80% of all skull fractures. Radiographs are usually required to diagnose a linear skull fracture because there are often no physical signs, such as deformity. That means what happens is you got a crack. It goes along in this line, as you can see here, okay? But no piece is missing. It's not deformed inward, so it's hard to tell if there's any significant deformity there. Now, depressed skull fractures. These result from a high-energy direct trauma to the head with usually a blunt object. The frontal and parietal bones of the skull are the most susceptible to this, and you get bone fragments that may be driven into the brain, resulting in injury. They often present with signs of neurologic injury, such as loss of consciousness. So right here, you can see that. Basilar skull fractures. These are associated with high-energy trauma, most usually following a diffuse impact to the head. These injuries generally result from extension of a linear fracture to the base of the skull, and usually need a CT scan to diagnose these. You can get a sign of a basilar skull fracture. That could be CSF drainage from the ears, or you could get a raccoon eye or a battle sign. Sometimes you'll see that. So you're more or less looking for the signs rather than seeing the obvious traumas on these patients. Open skull fractures. These are often associated with trauma to multiple body systems, usually a horrible situation. Brain tissue may be exposed to the environment, which significantly increases the risk of a bacterial infection, and they have a very, very high mortality rate, unfortunately. Okay, continuing on, we have traumatic brain injuries. These are the most serious of all head injuries. These are defined by the National Head Injury Foundation as a traumatic insult to the brain capable of producing physical, intellectual, emotional, social, and vocational changes. So they're classified into two broad categories: primary or direct injury, and secondary or indirect. Primary brain injury results instantaneously from impact of the head, and the secondary injury increases the severity of the primary injury. Secondary brain injury increases the severity of the primary injury and may be caused by things like cerebral edema, intracranial hemorrhage, increased intracranial pressure, cerebral ischemia, and infection. It could be hypoxia or hypertension as well. Those last two, hypoxia and hypertension, are the two most common causes of secondary brain injury and will increase death and disability significantly in a patient with head injury. These secondary injuries may occur anywhere from a few minutes to several days following the initial head injury. The brain can be injured directly by a penetrating object or indirectly as a result of external forces. So this could be, from blunt or penetrating trauma. You get what's called a counter-coup injury that can result from striking a windshield. The initial impact injures the front part of the brain, and then the head falling back against the headrest then injures the rear part of the brain. You have cerebral edema that may not develop until several hours following the initial injury. Low blood oxygen levels aggravate the cerebral edema, causing the swelling to be worse, causing the injury to be worse than it initially was. And so you want to monitor the patient for any seizure-like activity. Cerebral edema may not develop until several hours after the initial injury, so something we've got to keep an eye on. That's why we usually observe these patients in the ER for significant time. Low blood oxygen levels aggravate the cerebral edema, and then you need to monitor the patient for any seizure activities that occur throughout the stay. An intracranial pressure here, there's accumulations of blood within the skull or swelling of the brain that can rapidly lead to an increase in ICP. Increased ICP squeezes the brain against bony prominences within the cranium. Now, there's a couple ways to think about this. Number one is there's just a certain amount of things that are inside the skull, right? It's totally enclosed. And so you can only handle so much pressure. You've got blood, you've got brain products, you got everything else that's inside there. And so if you add anything else to that, air, trauma, blood, bleeding, hematoma, anything else to that is going to cause pressure, okay? Some of the signs of increased intracranial pressure. You get abnormal respiratory patterns such as ataxic or biot and Cheyne-Stokes, okay? So you get things like that is what you see often with these situations, okay? You can get decreased pulse rate, headaches, nausea or vomiting, decreased alertness. They become maybe bradycardic. You have non-reactive or sluggish pupils. It could even go into further posturing of decelerate posturing, increase or widen blood pressure. You get something called Cushing's reflex. This is the symptomatic triad of increased systolic blood pressure, decreased pulse rate, and then irregular respirations. These are all things that you'll see with these increased intracranial pressure. You have intracranial hemorrhage that is the cause of this. This is bleeding inside the skull that also increases the intracranial pressure. This can occur between the skull and the dura mater, beneath the dura mater, but outside of the brain itself, and then also within the tissue of the brain itself. Here's it lets you know about some of these things. And we're going to talk about this really quick here. So you can have what's called an epidural hematoma. Okay, so this epidural hematoma, this is accumulation of blood between the skull and then the dura mater. This is almost always the result of a blow to the head that produces a linear fracture. Okay, if this happens on the temporal bone, it's almost always that middle meningeal artery that runs along the groove of the temporal bone. The arterial bleeding into the epidural space results in a rapid progressing of symptoms there. Often the patient loses consciousness immediately following the injury. Then they'll sometimes come back, known as a brief period of consciousness or lucid interval, after which the patient lapses back into unconsciousness. People on the side of the hematoma becomes fixed and dilated because of the pressure, and then death can follow very rapidly without surgical intervention to evacuate that hematoma. So something we want to be very acutely aware of. A subdural hematoma, this is a little bit different, as you can see here. This is accumulation of blood beneath the dura mater, but outside of the brain. This occurs after falls or injury involving strong deceleration forces. they may or may not have a skull fracture association with this. This is more common than epidural hematomas and may or may not be associated with that fracture discussed above. Associated with venous bleeding, so the signs are typically developed more gradually than with the epidural hematoma, which is an arterial bleed. The patient often experiences a fluctuating level of consciousness or slurred speech, and any patient with suspected subdural hematoma needs to come to the ER and be evaluated. The intracerebral hematoma. This is bleeding within the brain tissue itself. This can occur following a penetrating injury to the head or because of rapid deceleration forces. So this is typically many small, deep intracerebral hemorrhages are associated with other brain injuries. The progression of increased ICP depends on the presence of other brain injuries. So the region of the brain involved and then the size of the hemorrhage. Intracranial or intracerebral hematomas have a high mortality rate even if the hematoma is surgically evacuated. The problem is it's damaging the actual tissue, right? Whereas the others are just pushing down on the tissue and may cause tissue damage. This is actually the tissue bleeding actually have problems. You have a subarachnoid hemorrhage. This is bleeding that occurs in the subarachnoid space where the CSF circulates. This results in bloody CSF and signs of meningeal irritation, sometimes some neck rigidity, might get a headache. Common causes include trauma or rupture of an aneurysm. Patient reports a sudden severe headache. As this bleeding increases, the patient will experience signs and symptoms of increased ICP, as discussed previously. A sudden severe subarachnoid hematoma usually results in death, and the survivors often have permanent neurologic impairment. Concussions. This is a blow to the head or face that may cause concussion of the brain. They're classified as mild traumatic brain injuries. It is a closed injury with the temporary loss or alteration of part or of all the brain's ability to function without demonstrable physical damage to the brain. About 90% of patients who sustain a concussion do not experience a loss of consciousness. Interesting to note, right? You think almost all the time you're going to have this concussion, there's going to be some loss of consciousness. Not so. Not the norm. A patient with a concussion may be confused or even have amnesia. This retrograde amnesia is the inability to remember everything but the events leading up to the injury, and anterograde amnesia is the inability to remember events after the injury. So one time when I was in high school, I was out wakeboarding, and I don't know what happened. I caught the front edge of my wakeboard there and just smashed my head on the water. I don't remember it. I just remember what my buddies have told me. Next thing I remember is I'm driving in my buddy's car and I'm like asking him a question. He's like super mad at me. He's like, why do you keep asking that question? Well, the reality is I'd asked the same question now like 30 times and I don't remember any of it. I just kept having this retrograde amnesia. I don't remember the things that had happened. I don't remember all those things that occurred. I had a little bit of anterograde amnesia. I don't remember what happened after the event until I was driving in the car. So I lost about, an hour and a half of my life, unfortunately. So, well, anyway, that's probably why. If you ever wonder what's wrong with Dr. Betts, it's because of that. Now, these usually last a short time, but you can ask about a lot of symptoms of concussions that they may have that go for quite some time. This could be dizziness, weakness, visual changes, change in mood, in any patient who sustains an injury to the head. You could also have things with nausea, vomiting, ringing in the ears, slurred speech, and inability to focus. Assume that a patient with signs and symptoms of concussion has a more serious injury until proven otherwise. We usually prove that by getting a CT scan in the ER. Bruising of the brain tissue results from blunt trauma. It's called a contusion. This is much more serious than a concussion. A contusion involves physical injury to the brain tissue. It may produce long-lasting and even permanent damage. A person who has sustained a brain contusion may exhibit any or all the signs of a brain injury. It's one thing to basically call this just a brain bruise, right? But this is essentially a brain bruise and much worse than a concussion. So, some of the other brain injuries that can occur. Brain injuries can also arise from medical conditions such as blood clots or hemorrhages. Problems with the blood vessels, high blood pressure, or other problems may cause spontaneous bleeding into the brain. The signs and symptoms of non-traumatic injuries are often the same as those of TBIs. So, pretty much the same symptoms. Anything that's going to cause irritation or injury or increased intracranial pressure has similar signs and symptoms. Okay, now we're going to go to spine injuries. The cervical, thoracic, and lumbar portion of the spine can be injured in a lot of different ways. Compression injuries can result from a fall, regardless of whether the patient landed on his or her feet or experienced a direct blow to the crown of the skull, coccyx, or top of the head. Forces that compress the patient's vertebral body can cause herniation of discs. Sometimes you get subsequent compression of the spinal cord and nerve roots, and then you get fragmentation into the spinal canal. This is an extremely dangerous situation. Motor vehicle crashes or other types of trauma can overextend or hyperflex the cervical spine and damage the ligaments and joints. You could also get rotational or flexional injuries of the spine. These results from rapid acceleration forces. Basically, any unnatural motions can result in fractures or neurologic deficits of these spine. When the spine is pulled along its length, you get hyperextension. It can cause fractures in the spine, as well as ligament and muscle injuries. When bones of the spine are altered from traumatic forces, they can fracture or move out of place. Permanent damage can occur in this situation. Some of the findings, you'll get with some significant pain and tenderness on palpation of that area. If you suspect these types of injuries, take extra precautions when stabilizing the patient's spine. All right, take a look at some of the patient assessment on all these things. You want to always suspect a possible head or spinal injury anytime you encounter one of the following mechanisms of injuries. Motor vehicle collision, especially motorcycles, snowmobiles, and ATVs. Pedestrians versus motor vehicle collision, falls greater than 20 feet for adults, 10 feet for pediatric. Any blunt head trauma, especially penetrating trauma to the head, neck, back, or torso. I'm going to be looking at that. Anything like a rapid deceleration injury, hangings, axial load injury, or a diving accident where they dive into the pool and hit their head. Scene safety. Evaluate every scene for hazards to your health and the health of your team or bystanders. Be prepared with appropriate standard precautions before you approach the patient in an MVC, and then call for advanced backup as soon as you might need. When we're evaluating the MOI or nature of illness, you want to look for any indicators of that, and then consider how the MOI produces the injuries that might be expected there. You want to focus, during the primary assessment, you want to focus on identifying and managing life-threatening conditions. Threats to circulation, airway, or breathing are considered life-threatening and must be treated immediately. Reduction of on-scene time and recognition of a critical patient increases the patient's chance for survival, or a reduction in the amount of irreversible damages, especially to these head and spine injuries. Spinal immobilization considerations. Be aware that any unnecessary movement of the patient can cause any additional injury. We don't want to do that. We want to minimize any of that. Begin by assessing the scene by determining the risk of injury, then form a general impression of your patient based on his or her level of consciousness and what their chief complaint is. If the patient is absolutely clear in his or her thinking and does not have any neurologic deficits, spinal pain or tenderness, evidence of intoxication or other injuries that may mask a spinal injury, you may consider not placing the patient in spinal restriction. The backboard is rigid and often places the patient in an anatomically incorrect position for a long period of time. Therefore, we're moving away from using this, okay? It can cause circulation to areas of skin that can become compromised. Some patients could experience respiratory compromise while laying flat. So you want to minimize the time the patient's on a backboard if they need it. Cervical collar. You want to apply as soon as you have assessed the airway and breathing and provided necessary treatments. Once the cervical collar is on, don't remove it unless it causes a problem with maintaining the airway or the patient shows signs of increased ICP. If the device needs to be removed, maintain manual stabilization of the cervical spine until it has been replaced. Assessing for signs and symptoms of head or spine injury. Begin by asking the responsive patients questions like this. What happened? Where does it hurt? Does your neck or back hurt? Can you move your hands and feet? Did you hit your head? Confused or slurred speech, if they're repetitive questioning like I was, or amnestic in responsive patients are good indicators of a head injury. In the setting of trauma, assume your patient has a head injury until your assessment proves otherwise. Unresponsive trauma patients should be assumed to have a spinal injury. Patients with a decreased level of consciousness or responsiveness, ABPU scale, is what you'll kind of base that on, that should be considered to have a spinal injury based on their chief complaint. Airway, breathing, and circulation considerations. So when a spinal injury is suspected, how you open and assess the airway is very important. Manually holding the patient's head still while you assess the airway. You want to use a jaw thrust maneuver to open the airway. If the jaw thrust maneuver is ineffective, it is acceptable to use the head tilt chin lift maneuver as a last resort. Vomiting may occur in the patient with a head injury. It's often a sign, especially if there is some increased intracranial pressure. Irregular breathing, such as Shane Stokes, may result from increased pressure on the brain as well. So you can administer a high flow oxygen. This is indicated for patients with head and spinal injuries. You can get pulse ox values should not fall below 90, and ideally should be 95 or higher. Hyperventilation or ventilating too fast or too much force. You want to use only capnography if it's available, but ensure that the end tidal CO2 level is between 30 and 35. It's easy to get a little overzealous on these. A pulse that is too slow in the setting of a head injury can indicate a serious condition in your patient. We're looking at that Cushing syndrome, that bradycardia. A single episode of hypoperfusion in a patient with head injury can lead to significant brain damage and even death. So we do not want them to become too hypoperfused. Assess for signs and symptoms of shock and treat appropriately, and you want to do your best to control the bleeding. Manner of transport. Severe transport consideration, or several may be considered, and they should be kept in mind with patients of significant head trauma. Patients with impaired airways, open head wounds, or abnormal vital signs, or patients who do not respond to painful stimuli may need to rapidly extract from motor vehicle collision and transport rapidly. Ensuring a patent airway and providing high flow oxygen is paramount. There is a probability of vomiting and seizures, so suction should be always available. A head trauma patient may deteriorate rapidly and require aeromedical transport. In supine patients, the head should be elevated 30 degrees if possible to help reduce any intracranial pressure. Remember that you want to maintain the mobilization of the spine. Okay, we're going to move into history taking for just a little bit. You want to investigate the chief complaint, obtain a full medical history, and be alert of injury-specific signs and symptoms, as well as any pertinent negatives. You could use the OPQRST. This may provide some background on isolated extremity injuries. Gather as much sample history as you can while preparing for transport of your patient. On your secondary assessment, you want to take a look at a number of things. One of these, and most important, is the ability to walk, to move the extremities, or feel sensation, as well as the absence of pain. This doesn't necessarily rule out a spinal cord injury. So because of that, you want to instruct the patient to keep still and not move to the head or neck at that time. On physical examinations, there may be a systemic head-toe full body scan or systemic assessment that focuses on a certain area or region of the bodies. Time allows for a secondary examination while en route to the hospital. Obtaining a complete set of baseline vital signs is always essential. In addition to hands-on assessment, you should use monitoring devices to quantify a patient's oxygenation and circulatory status. Maintain your CO2 between 35 and 40, SpO2 above 95, hopefully. But you want to take a look at the vital signs of significant head injuries. May cause the pulse to be slow, as we talked about before. Also, blood pressure may rise. With neurogenic shock, the blood pressure may drop, and the heart rate may increase to compensate. And then respirations will become erratic as well. So a couple things to look forward to. You could use the DCAP, BTLS, to examine the head, chest, abdomen, extremities, and back, and then check perfusion, motor function, and sensation in all extremities. You want to check them prior to moving the patient. Remember that some things that you'll look for and see is that a decreased or altered level of consciousness is the most reliable sign of a head injury. Determine whether there is decreased movement or numbness and tingling in any extremities. Look for blood or CSF leaking from the ears, nose, or mouth, and for bruising around the eyes and behind the ears. Assess pupil size and reaction to light and continue to monitor the pupils. Do not probe open scalp lacerations with your gloved finger because this may push bone fragments into the brain. And do not remove an impaled object from an open head injury. On your neuro exam, you want to perform a baseline assessment using a Glasgow Coma scale, the GCS scale, from 3 to 15. If your jurisdiction uses the revised trauma score, then the findings from GCS will be used in determining the RTS value. And then you want to record that level of consciousness that fluctuated or deteriorated as you continue to observe the patient. here's your GCS, right? This is something you want to memorize and know extremely, extremely well. I imagine this will be on all your exams, but in your daily use, this is extremely important. You have eye-opening, verbal, and motor response, okay? And you're going to want to know these at any point in time. This helps you understand the level of consciousness, how well the patient's responding, what they're looking like, and is the language that everyone speaks in emergency medical services. On your spine exam, you can use the DCIP, BTLS, and check the extremities for circulation, motor or sensory problems. If there's impairment, note what level you see that at. Pain or tenderness when you palpate is a warning sign that a spinal injury is likely present. Other signs and symptoms include an obvious deformity, if there's any numbness, weakness, tingling of the extremity, and soft tissue injuries at the spinal region. And then obvious injury to the head or neck may indicate injuries to the cervical spine, so you want to take all precautions there. On your reassessment, you want to repeat the primary assessment, repeat your vital signs and the chief complaint. Then recheck how your interventions are doing. You want to do this at least every 5 minutes or so. You want to compare your baseline vital signs with your repeated vital signs. Are you improving? Are you getting better? Are you worsening? Rapid deteriorations of neurologic signs following a head injury is a sign of an expanding intracranial hematoma or rapidly progressing brain swelling. So we want to be sure we're on top of that. If CSF is present, cover the wound with sterile gauze to prevent further contamination, but do not bandage it too tightly. That means their pressure is increasing significantly in that area. Your protocol should include the administration of high-flow oxygen and the application of a cervical collar, if indicated, as part of spinal immobilization. Reassessment should take place as the patient is transported to an appropriate trauma facility. So you want to consider all those things. On your communication and documentation. Your documentation include a number of things, but you want to be as complete and as detailed as you can be. And that helps the destination facility and helps everyone else down the line from you. Hospitals may better prepare for seriously injured patients with more advanced warning and a description of the most serious problems found during your assessment. More seriously injured patients should have documented vital signs every 5 minutes. More stable patients should have them at least every 15 minutes. You may be requested to testify as a witness, so you want to make sure that you write the best you can, give the best story as to what you did. I don't practice based on worry about litigation. However, knowing that will occur at some point in time for all of us professionals, it's good just to make sure that they see a great person trying to do a really great job. So let's talk about some general principles of the medical care of head injuries. Number 1, establish an adequate airway. 2, control bleeding and provide adequate circulation to maintain cerebral perfusion. And then assess the patient's baseline level of consciousness and continuously monitor that. Always want to be rechecked that. The most important step in establishing and maintaining an adequate airway is this. Once the airway is open, maintain the head and cervical spine in a neutral, inline position until you have placed a cervical collar and have secured the patient on a backboard. Okay? So this is the most important step in establishing that. Is get it maintained and then get that collar on. This figure shows how you can do this. Okay? So you can apply that through collars you finish the primary survey, especially with 2 people working. One can hold the spine in place while you do this primary assessment and apply the collar. You want to remove any foreign bodies or secretions or vomitus from the airway. You can use it with suction. Once you have cleared the airway, then check your ventilations. You want to give some oxygen to any patient with suspected head injury, particularly anyone who's having some trouble breathing. Use a BBM to assist ventilation if the patient is breathing too slow or too shallowly. Placement of an airway device may be necessary to maintain airway patency. And consider calling ALS if the patient's airway is compromised. On the circulation, you must begin CPR if the patient is in cardiac arrest. You want to begin that immediately. Active blood loss aggravates hypoxia. Bleeding inside the skull may cause the intracranial pressure to rise to life-threatening levels. You can almost always control bleeding from a scalp laceration by applying direct pressure over the wound. If you suspect a scalp fracture, though, do not apply excessive pressure to the open wound. If the dressing becomes soaked, do not remove it. Place a second dressing over the first. Hopefully that'll help to clot it or give a little bit of back pressure there. Shock in these situations. This is usually the result of hypovolemia, okay, caused by bleeding from other injuries, or that head injury is so significant. You want to transport immediately to a trauma center. You get something called Cushing's triad. We talked about this a little earlier. You get increased blood pressure, hypertensive, decreased heart rate, this is bradycardia, and irregular respirations. That's Shane Stokes or BIOT respirations. You want to try to manage shock, administer oxygen if ventilate is necessary, avoiding hyperventilation. If this process is allowed to continue, it will be a fatal injury. You want to remember to follow your standard procedures and your precautions, right? Maintain the patient's airway while keeping the spine in proper position. Assess respirations. Give supplemental oxygen. Again, on managing the airway, first start with performing the jaw thrust maneuver to open the airway. Consider inserting an OPA. Have a suctioning unit available and provide supplemental oxygen. Here's an example of what we're doing there, that jaw thrust maneuver, okay? Neck is in neutral, inline position, and then push the angle of the jaw forward. Spinal motion restriction of the cervical spine. Immobilize the head and trunk so that bone fragments do not cause any further damage. This is the idea that we're trying to save the patient by this way. Even small movements can cause significant injury to the spinal cord. So you can use skill drill 29.1. Never force the head into a neutral or inline position. Do not move the head any farther if the patient reports any of the following symptoms: muscle spasms of the neck, substantial increased pain, numbness or tingling, or weakness in the arms or legs if there's compromised airway or ventilations. Here's a picture of your cervical collar. These provide preliminary partial support. They should be applied to every patient who has a possible spinal injury based on the mechanism of injury, history, or signs and symptoms. To be effective, a rigid collar must be the correct size for the patient. Once the patient's head and neck have been manually stabilized, assess the pulse, motor functions, and sensation in all extremities. Then assess the cervical spine area and back. You want to maintain manual support until the patient has been fully secured to the backboard or vacuum mattress. Supine patients. You want to secure the patient to a long backboard or vacuum mattress. Another procedure to move a patient from the ground to backboard is the 4-person log roll. You may also slide the patient onto a backboard or vacuum mattress. So you can follow the steps in skill drill 29.3. Vacuum mattress. Alternative to long backboard is a vacuum mattress. Molds to the specific contours of the patient's body, reducing pressure point tenderness and therefore providing better comfort. Also provides some thermal insulation, helps them stay warm. Excellent for the elderly or patient with abnormal curvature of the spine. Drawbacks to the device is its thickness. It requires careful patient movement to maintain spinal stabilization. It cannot be used for patients who weigh more than 350 pounds. Can be used on a supine, sitting, or standing person. So some pros there. Patient can be moved onto the vacuum mattress with a scoop stretcher or using a log roll. Sitting patients. Use a short backboard or other short spinal extraction device to restrict motion and movement of the cervical and thoracic spine. Then secure the short backboard to the long backboard if needed. Exceptions to this rule would include things such as you or the patient's in danger. You need to gain immediate access to the other patients. The patient's injuries justify urgent removal. Skill drill 29.5 will help us with some of these things. On the standing patients, a patient who is already standing and walking should be able to sit down gently and be transferred to a position in which spinal motion restriction can be maintained. If the mechanism of injury and clinical indications suggest spinal injury or the patient's inability to protect his or her spine, establish spinal motion restriction. Okay, and some of these things that might make you do this would be spinal tenderness or pain, and altered level of consciousness, neurodeficits, if they've got an obvious anatomical spine deformity, or if you have a high energy trauma in a patient intoxicated from drugs, alcohol, or distracting injury, they may not be aware. Spinal immobilization devices. During assessment, pain in the spine may be dismissed because of shock or because the patient's attention is directed to more painful injuries. Because any manipulation of the unstable cervical spine may cause permanent damage to the spinal cord, you must assume the presence of spinal injury in all patients who have sustained head injuries. Use manual inline stabilization or a cervical collar and long backboard in this case. Okay, short backboards. This is the most common one that you'll see. They're a vest-type device and the rigid short board. Designed to immobilize and restrict movement of the head, neck, and torso. Used to immobilize non-critical patients who are found in a sitting position and have possible spine injuries. Right, so there's a couple different uses for this. Now the backboards are kind of, as we talked about over the years, if you're new to this now, they used to backboard everybody and then give them a cervical collar. Now we're like cervical collar everybody and then backboard when you absolutely need to. That'd be the same for the short transport or short board. The long backboard provides full body spinal immobilization and motion restriction to the head, neck, torso, pelvis, and extremities. Used to immobilize patients who are found in any position, sometimes in conjunction with short backboards. Now this, if you find somebody have multiple traumas and you've got like a hip dislocated or a hip fracture, and you're worried about spine fractures, you're worried about head injuries, those kind of things, and that's when you want to use these full boards. Or if it's much easier for you to transfer the patient. You could talk to your advanced and your paramedic folks about when they choose to use these. They may know even better than me. Scratch that. They do know better than me. Helmet removal. A helmet that fits well prevents the patient safe from moving and should be left on. Provided there are no impending airway or breathing problems. It does not interfere with assessment and treatment of airway or ventilation problems. And then you can also properly immobilize the spine. So you want to remove a helmet if it's a full face helmet. Okay, it makes assessing or managing airway problems very difficult, and removal of a face guard to improve airway access is not possible. It prevents you from properly immobilizing the spine. It allows excessive head movement, and the patient is in cardiac arrest. For all those reasons, you want to remove a helmet. Preferred method. Removing a helmet should always be at least a two-person job. Technique for helmet removal depends on the actual type of helmet worn by the patient. You and your partner should not move at the same time, meaning one of you should be holding at all times, the other person moving. You should first consult with medical control about that decision to remove the helmet. And then Schedule 29.6 shows some great ways to do this. There's an alternative method. The advantage of this method is that it allows the helmet to be removed with the application of less force, thereby reducing the likelihood of motion occurring in the neck. Disadvantage is this is slightly more time consuming. On the alternate method, you go through this way. You remove the chin strap, remove the face mask, cut or unscrew the plastic clips, pop the jaw pads out of place with a tongue depressor. Place your fingers inside the helmet during removal of the helmet. The person at the side of the patient controls the head by holding the jaw with one hand and the occiput with the other. Insert padding behind the occiput to prevent neck extension when you're finished. The person at the side of the patient's chest is responsible for making sure that the head and neck do not move during the removal of this helmet. Remember that small children may require additional padding to maintain their inline neutral position. Okay, time to review. Okay, question 1. The brain, a part of the central nervous system, is divided into what? Those are your options there. Take a look, make your decision. A, the brain and spinal cord comprise the central nervous system. The brain is divided into 3 major regions: the cerebrum, and the largest portion, the cerebellum, and the brainstem. Each region of the brain carries out specific functions. Okay? Gives you some of your rationale as to what is not part of that. As you are assessing a 24-year-old man with a large laceration at the top of his head, you should recall that A, the scalp, unlike other parts of the body, has relatively fewer blood vessels. B, blood loss from scalp laceration may contribute to hypovolemic shock in adults. C, any avulsed portion of the scalp should be carefully cut away to facilitate bandaging. D, most scalp injuries are superficial and are rarely associated with more serious injuries. Okay. Make your choice. B, although the scalp is highly vascularized and tends to bleed heavily when injured, scalp injuries are rarely the sole cause of hypovolemic shock in adults. However, they can contribute to hypovolemia, caused by injuries elsewhere in the body. Scalp plaques, whether deep or superficial, should prompt you to look for more serious underlying injuries such as a skull fracture. If the injury involves an avulsion, the avulsion flap of skin should be carefully replaced to its original position, not cut away. So there's some of your rationale. Most of the answered that rationale already. Number 3, a patient who experiences an immediate loss of consciousness followed by a lucid interval has which of the following? Epidural hematoma, subdural hematoma, concussion, or contusion. Okay, you have your selection. A. Epidural hematomas, they're caused by injury to an artery, usually the middle meningeal artery that lies between the skull and the brain. Patients with an epidural hematoma typically experience an immediate loss of consciousness, followed by a brief period of consciousness, or a lucid interval, as intracranial pressure increases. Subdural hematomas are the result of injury to a vein. Therefore, they tend to bleed slowly and usually cause a progressive decline in level of consciousness. Concussions, contusions may cause a loss of consciousness, but it is typically very brief. Here's some of your rationale. Number 4, a 44-year-old man was struck in the back of the head and was reportedly unconscious for approximately 30 seconds. He complains of a severe headache and seeing stars, and states that he regained his memory shortly before your arrival. His presentation is most consistent with what? Contusion, concussion, subdural hematoma, intracerebral hemorrhage. B. Concussion occurs when the brain is jarred around inside the skull. It may result in brief loss of consciousness and occasionally amnesia. Seeing stars is a common finding following trauma to the back of the head or the occipital region, as this region is primarily responsible for vision. A concussion, the least severe of all closed-head injuries, typically does not result in physical damage to the brain. Compared to a concussion, a contusion, subdural hematoma, and intracerebral hemorrhage are usually associated with a more prolonged loss of consciousness. So here's some of the rationale. Okay, number 5. A young male was involved in a motor vehicle accident and experienced a closed-head injury. He has no memory of the events leading up to the accident, but remembers that he was going to a birthday party. What is the correct term to use when documenting his memory loss? Concussion, cerebral contusion, retrograde amnesia, anterograde amnesia. Again, no memory of events leading up to the accident. Term amnesia means loss of memory. It is common in patients who have experienced a cerebral contusion. Amnesia of events leading up to an injury is called retrograde amnesia. Anterograde amnesia, also called post-traumatic amnesia, is the inability to remember events that occurred or will occur after the injury. Here's some of your rationale, okay? Six, a distraction injury in the cervical spine will most likely occur following a driving accident, blood neck trauma, hyperextension of the neck, or hanging tight. The key is, what does a distraction injury mean? D. Excessive traction on the neck, such as what occurs during hanging tight mechanisms, can cause a distraction injury of the cervical spine. Distraction injuries can cause separation of the vertebrae and stretching or tearing of the spinal cord. Here's your rationale, and which each one of those would cause, which type of injury they would cause. Number 7, during immobilization of a patient with a possible spinal injury, manual stabilization of the head must be maintained until an appropriate size extraction collar has been placed, the patient is fully immobilized on a long backboard, a range and motion test of the neck has been completed, pulse monitor and sensory functions are found to be intact. All right, make our selection. B. Manual stabilization of the patient's head must be maintained until he or she is fully secured to the long backboard. since you suspect a spinal injury. This includes the application of an extrication collar, straps, and lateral immobilization head blocks. Pulse, motor, and sensory functions must be checked before and after the immobilization process. Do not assess range of motion in a patient with a possible spinal injury. This involves moving the patient's neck and then may cause further injury. Here's some of your rationale. So the collar is just part of that. That's why that one's not correct. You're going to say, well, they need to get that on first. And you're not wrong. That's for sure. Your patient is a 21-year-old male who has massive face and head trauma after being assaulted. He is lying supine, is semi-conscious, has blood in his mouth. What should you do? A. Insert a nasal airway, assess his respiration, give 100% oxygen. B. Suction his airway and apply high flow oxygen via non-rebreather mask. C. Manually stabilize his head, log roll him onto his side, and suction his mouth. D. Apply a cervical collar, suction his airway, and begin assisting in ventilations. Okay. C. Blood or other secretions in the mouth place the airway in immediate jeopardy and must be removed before they're aspirated. At the same time, you must protect the patient's spine due to the mechanism of injury. Therefore, you should manually stabilize the patient's head, log roll him onto his side, allows drainage of blood from his mouth, and suction his mouth for up to 15 seconds. After ensuring that his airway is clear, assess his breathing and give high flow oxygen or assist his ventilations. Nasal airways should not be used in patients with severe facial or head trauma. Again, here's some of your rationale, okay? Number 9. A man is found slumped over the steering wheel, unconscious and making snoring sounds. After an automobile accident, his head is turned to the side and his neck is flexed. You should A. Gently rotate his head to correct the deformity. B. Carefully hyperextend the neck to open his airway. C. Apply an extrication collar with his head in the neutral position. Manually stabilize his head and move it to a neutral inline position. D. The patient's snoring sounds indicate an airway problem, which must be corrected or he may die. Manually stabilizing his head, carefully move it to a neutral inline position and reassess his breathing. Don't rotate or hyperextend the neck of a patient with possible spinal injury. Results could then be disastrous. Here's some of your rationale. Last question. You should not remove an injured football player's helmet if a cervical spine injury is suspected, even if the helmet fits loosely. The patient has a patent airway, even if he is breathing difficultly. He has broken teeth, but only if the helmet does not fit snugly in place. The face guard can easily be removed, and there is no airway compromise. Okay, last selection there. You generally should leave a helmet on if it fits snugly and does not allow movement of the head within the helmet. The patient's airway is patent. No airway problems are anticipated, and the patient is breathing without difficulty. If you can easily remove the face guard, often the case with football helmets, and there are no airway problems, do so, but leave the helmet on. If the helmet is loose, the airway is in any way compromised, or the patient has difficulty breathing, or is in cardiac arrest, the helmet must then be removed. So here's your rationale. Okay, so all those other ones we need to remove because of those reasons. Okay, hope that was a good review. Thank you so much for coming and listening. This was fun, head and spine injuries. I will see you soon. Have a great rest of your day, and hope to see you in class soon.